Well, thanks very much. It is fun to be here again after 20 years. And it was a great privilege to be able to participate in the 2002 guidelines and the 2012 guidelines under the leadership of Adira Levin and Paul Stevens. And I really look forward to the fact that we will generate some discussion and a document here that hopefully will be able to sync nicely with the work group plan and the forthcoming guidelines from their deliberations. I'm also thrilled to be here at an in-person meeting. This is really a good thing. Although the one thing I do regret is when I get these difficult questions, I just can't say, "I'm sorry, you're on mute." I always begin with this slide because the work that I've done in my career, and in fact some of the formative work for the 2002 and the 2012 guidelines, was actually produced by the CKD Collaboration, the CKD Prognosis Consortium. I think this has been some of the work that has driven the GFR principles so deeply into practice. And I, of course, want to acknowledge the deep collaboration with Joe Korish, Tom Green, and Leslie Inker. Leslie now is the co-director of CKD. And anything that I agree to do as a research project here, she'll have to approve. So I'll speak quite freely. This is a different sort of topic from the others. I actually think the GFR evaluation part of the 2012 guideline does quite a good job. At the same time, there have been advances since then, and I'll go over a few of those areas, and I think that they ought to be incorporated into the new guideline. And there's also been some stagnation in implementation, as well as research, that I think we should try and activate. I'll show you sort of the way I put this together. I think that as far as driving quality of care, it's all about developing an international guideline, and it's all about implementing it. So what I think needs to be done to improve quality care, I'm going to try and link very closely to what the current guidelines say and what I think is missing from the current guidelines. I don't think this deviates too far from the task because I'm not trying to write a new guideline. Right? That's the prerogative of another group, but I think it's important for us to focus on those areas. So I'll start off with the general topic of GFR evaluation. This isn't about just equations or filtration markers. This is the general topic and how to think about this, both from a clinician point of view and a research point of view. I'll talk about the measured GFR, estimated GFR, reporting the estimated GFR, because I think that's a key consideration for clinical practice. I'll give my conclusions and highlight again where I think we can improve quality of care. And if we have time, I'll show you a list of research questions, but I, of course, understand that this comes out of the discussion group as well. I'm going to use a format that looks like this. On the left, where it says principles and practice, this was what would go into the narrative of the guideline, right? And we're improving quality of care, this would really be the recommendations from the guideline. And every time you see the little KDIGO symbol, that means it's there already. And when it's not there already, right, that means there's something new in the literature, something new in our way of thinking that I think ought to be added there. And the stuff in red I think is really important. So for GFR evaluation, the first thing is that the GFR is the quantity of interest, the true GFR. But this can't be measured directly, right? Clearance measurements are not a direct measure of GFR, and estimations from plasma concentrations are not a direct measure of GFR. So we're dealing with uncertainty here in this measurement. Now, we're dealing with uncertainty with every new measurement that we bring on, but I think there's inadequate appreciation of this uncertainty. And this actually affects everything that we do that's keyed to using the GFR as the yardstick by which we evaluate other measures. And the second thing is that we know that GFR varies with kidney size. This is proportional to body size, and indexing is what we usually use for normative data, and I think this is correct, but we need to understand that indexing actually doesn't affect accuracy, right? If you change the index value from 1.73 to 2.0 meters squared, which is a closer value to the current body surface area of people in the United States, it doesn't change the accuracy of the GFR. It changes the number, right? But it doesn't change how accurately you can measure it or how accurately you can estimate it. We use GFR for the definition, staging, clinical action plan, and the recommendations. We don't use MGFR. We don't use EGFR. We're talking about the hypothetical concept of GFR, right? Because we don't have different thresholds based on the measurement method, right? We don't have different normative values based on the measurement method. So we're trying to think of a concept, a hypothetical concept, that we can use to judge whether the patient has kidney disease, how serious it is, what we should do. This gives the clinicians a lot of leeway, but as researchers, we still want our methods, right, to be precise. We still want our methods to be well calibrated. We want them to be reproducible, and we don't want to be lazy and say, you know, I didn't want to work so hard, right? I just want to take the first EGFR, right? We want to actually get the most accurate assessment we can. So I think we need to acknowledge errors in EGFR and MGFR, and most important, because this is not an exact measurement, we need to tailor this for use in a clinical context with other variables. When we talk about what the GFR is, that's not the only measurement we need, right? We need to go beyond that. We need the albuminuria, for example, in order to judge prognosis. We need to understand how sick the patient is in order to understand drug dosing. It's not just the GFR that determines drug dosing. And we need to use other variables in risk prediction, right? So I think that the GFR needs to be used in the context of the decision that needs to be made, right? It's not the end of the evaluation. I think that we need to continue to use index GFR for definitions and classifications for most decisions, but we need to use non-index GFR when people have extreme body surface area, either very high as in morbid obesity or very low as in wasted people, and particularly when we have changes in BSA, right? Because you may not have a change in GFR, but if you reduce your BSA, for example, after bariatric surgery, right, the index GFR will go up, right? But the true GFR could be going down. So here's just a scanning EM of the glomerulus to show you it's 180 liters are produced by 1 million of these. We can't possibly measure this in vivo in humans. Everything we're doing is an estimate. This is the way I would propose that we do the GFR evaluation. This is what's proposed in the guideline. The initial test is the eGFR creatinine. We try and get an assessment of where GFR is on this big scale. We then routinely consider sources of error and the need for a more accurate estimate. If we're content that the sources of error that are inherent in our eGFR creatinine are sufficient for decision making, we don't need a confirmatory test, and then we put that into whatever clinical application we're going to use it, but with other information. Okay? If it's not accurate enough, we perform confirmatory tests. So this part is in the guideline, the initial test and the confirmatory test, but the idea that we consider these sources of error, right, that we do confirmatory tests more frequently, and that we fit the evaluation to the application is really not in the guideline. Here's where we think we are with accuracy. The best we can really do with estimating equations is to get the P30 up to about 90%. The P30 is the proportion of estimates that are within 90% of the measured GFR. It's very hard to get better than this. Our routine creatinine equations get us to maybe 80, 85%. I think we're at the ceiling of that. I don't think we can do better with creatinine equations. I think the proliferation of creatinine equations is not going to improve this. With an additional marker like cystatin, you can get above 90%. With multiple markers, you can get even better than that, but you can't get a whole lot better than this, but you can reduce the dependency on other variables such as age, sex, and race, okay, which I think is very important. Now, with measured GFR, you really can't do much better than getting the P15 above 90%. The P15 would be the proportion of measurements which are within 15% of the truth, okay? So P15 of 90% is a whole lot better than a P30 of 90%, but it's not that the measured GFR is the truth, right? There are differences in measurement methods, right? And I think this is not particularly appreciated, and in particular, this imprecision in the measured GFR drives the accuracy of the estimates down. Right? One of the reasons you can't get better than 90% is because you have error in the gold standard. So there's a very nice paper that Levey, Inker, and I wrote an editorial about, and we identified the conditions which affect the biological variability and the analytical variability of MGFR and EGFR, and I think this needs to be appreciated a little bit better. Here's a study by Alex Chang and people at Hopkins and Levey, Inker, and I, where Alex just measured the GFR in 27 people before and after bariatric surgery. And you can see that the BSA declined from 2.42 to 2.12 in these patients. This went along with about a 14-kilo weight loss. And you can see the non-indexed GFR went down a little bit, on average 120, okay, down to about 110. The indexed GFR went up from about 80 to about 90. So when we're looking at the GFR in someone before and after bariatric surgery, I think we want to know what happened to the kidney, not what happened to the body surface area. Right? So this is an indication for a place where we could use non-indexed GFR. It's very easy to convert them, and you don't lose anything in the accuracy when you convert them. Regarding measured GFR, we already have an elaboration of a rigorous concept for the relationship of GFR to clearance of filtration markers. Homer Smith, is even older than I, so we know this pretty well. But Homer Smith's method is not used anywhere. Right? Inulin is in short supply, and nobody does the kind of clearances that he did. There are many alternative methods, but these have varying accuracy, bias compared to the reference method, imprecision of repeated measurements. I think we need a national and international effort to facilitate the increased routine and timely use of measured GFR. Right? But this means we're going to need to overcome laboratory and reimbursement barriers. I think that clinical laboratories that offer measured GFR should standardize them and calibrate them to the reference method. This doesn't exist, right? Some people do a radionuclide GFR. Some people do urinary clearance of DTPA. Some people do plasma clearance. They're not all the same, right? And when we talk about, calibrating our MRI methods from one machine to the next, I think we actually have stagnated here. We don't have reference methods for these. There has been a systematic review. I think this is a good start. I don't think it's good enough. They actually compared each of the methods to urinary inulin clearance, right? Being good enough was within 30%, right? We can estimate it that well, all right? Strong evidence for sufficient accuracy compared to Smith. That was the urinary clearance of iothalamate. Moderately strong urinary and plasma clearance of 51 chromium EDTA, plasma clearance of iohexol. Limited clearance urinary DTPA, urinary iohexol, plasma clearance of inulin, inaccurate. Strong evidence, endogenous clearance creatinine, limited evidence for inaccuracy, plasma clearance of DTPA, and it's well acknowledged that the imaging methods do less well than the clearance methods derived from urine and blood. Okay, but I would say if we took a survey, and we've suggested that there be an international survey, that a lot of you are using measures which don't make it here. Paul Stevens and his colleagues did a nice study looking at the biological and measured and biological variation of measured and estimated GFR in people with CKD, GFR with from about 30 to 60, I believe, and the analytical variability of measured GFR was higher than creatinine, cystatin, and the currently available equations that they tested. The within-person variability, the time-to-time variability was also higher for measured GFR. Now, this doesn't mean that we shouldn't do measured GFR. We should just be aware of the fact that it's a hard measurement to do. So my conclusions regarding estimated GFR, we already have in the guidelines that there's a rigorous concept to relate mGFR to serum concentration of endogenous filtration markers. And the guidelines already talk about equations based on linear regression of observed variables. The guidelines came out, I think, after the FAST method, which uses assumed relationships between these variables, had acquired a large amount of data, and I think the FAST method really does quite well. Right? And so I think this needs to be added to the guideline statements that in addition to observed variables, there is this other method to develop equations. The guideline statements don't say that the bias and imprecision of measured GFR affects the eGFR evaluation and should be taken into account when doing those research studies. The guideline says that the first test is serum creatinine and eGFR, and the P30 of that is 80 to 90%. It acknowledges differences in non-GFR determinants across regions and countries, but the guideline doesn't say anything about the use of race as a covariate. This, of course, became a big deal in the US, and I'll show you a slide about that in a moment. I think this question will hit Europe. I think this question will be relevant for the next guidelines, and I think it will need to be dealt with head-on, as opposed to thinking that it's not relevant in other parts of the world. Regarding a continuation of this, the guidelines do say that multiple filtration markers increase robustness of each marker and reduce the dependence on demographic variables. It does say that the non-GFR differences in cystatin across regions and countries are smaller than creatinine. It doesn't say much about the use of a panel because this is new. This is important. This is an important advance looking towards the future. It does say use cystatin as a confirmatory test and that the P30 can be this high, but cystatin is markedly underutilized. And I think we need to do something about this. All right? And I think it requires recommendation in the guideline. I think it requires action, and this is not just for doctors. Right? This has to be done by organizations and societies. First, we need specific recommendations for other settings. We thought that if you said, when creatinine's not accurate, don't use it, we thought that people knew what we meant. That's not enough. We need to say, use it in patients with large limb amputation, spinal cord injury, neuromuscular disease, severe malnutrition, advanced heart failure, liver disease. There's a whole list of others. The list ought to be in there because if you put the list there, insurance companies look at the list and they'll reimburse the lab. Right? If the lab can get reimbursed, then the patients don't pay the bill. Then we'll order the test, and then the cost of the test will come down. Everything is cheaper than a serum creatinine. Every test in the world is cheaper than a serum creatinine. The fact that a new test is more expensive than creatinine is probably not a good enough reason not to do the new test. We also need to say, what are the conditions when greater accuracy than eGFR can provide is needed, for example, for kidney donation, dosing of drugs excreted by the kidney, drugs with narrow therapeutic index, drugs with serious toxicity. And once again, we're going to need to reconsider race as a covariate in any equation that includes creatinine. Now, the race issue came to a head in the United States for completely justifiable reasons. We felt that the best way to try and get things back on track as far as having a uniform way to estimate the GFR, despite this, was to remove race as a covariate in the existing data sets. And we have published a series of papers now, this first one in the New England Journal, and then a more recent publication by CKD and JAMA, where we've tried to clearly outline what are the implications for accuracy compared to measured GFR, prevalence of CKD in the United States using NHANES database, and implications for risk prediction in black and white patients. And this is important to know, and I have several slides here, but I'm just going to flip through them because we can talk about this in more detail. I think this is not just a US question. I agree. It took me a while to come to the fact that we needed to make a change, even though this changes the performance of the estimating equations. Right? I think it's not justifiable to continue to use race in GFR estimating equations. And if you drop the race term from the current equations, you're still using an equation that includes race, because the factor of 1.0, right, in the current equation is conditional on the fact that you get a better fit if you assign the blacks a factor of 1.59, right? So we're really not counting the data from the black patients in the current equation if we just use the white term. So for GFR reporting, the guidelines already say we ought to use standardized serum assays. This has been done for most instrument manufacturers for serum creatinine, but you know, I think that it's not uniformly implemented. I think in the US, we think this is around 90+%. I'm not sure this is true in the rest of the world, and there was a recent article by Vivek Jha describing how in many parts of Asia and in South America, they don't have access to standardized creatinine assays. This was new to me, okay? But I think if it's true, this is something we need to overcome. You can't possibly get a comparable estimate if you don't use a standardized assay. I believe this is language from the joint NKF and ASN task force to make recommendations about use of race in GFR reporting about cystatin, national and international efforts to facilitate increased routine and timely use of cystatin C. This to me means overcoming laboratory and reimbursement barriers, and this means working on systems, not just individual doctors complaining it takes too long to get a cystatin. We should report the eGFR whenever the filtration marker is measured. This is not routinely done. We should use a single equation for each filtration marker or a combination of filtration markers if we can. Now, you know, we might not be able to because it's just not accurate enough. In Japan, they use a different equation because the equation that we've used in the US and Europe doesn't work well. We can't make people in Japan use an inaccurate equation, but we have to appreciate there's going to be a trade-off between accuracy and uniformity. Okay? We have to appreciate that accuracy is good, uniformity is good, and that we're not going to be able to have both with the creatinine equation. So we have to accept some sort of trade-off here. We need to use an equation for general use rather than for use in subgroups. I'll show you an example of that. And then I think it would be nice to report the eGFR non-indexed for BSA as well as indexed, particularly if the lab information system has the height and weight, right? That will help us out in some problematic patients and in drug dosing. So here's the National Kidney Foundation Laboratory Engagement Working Group recommendations for implementing the race-free equations and for implementing the cystatin equations. This provides some very useful information which I think can be taken up into the guideline. here's the performance of the CKD epi equations, the creatinine, cystatin, and creatinine cystatin equations across various subgroups. Notice the difference in diabetics, for example, but also difference by BMI, very little difference by sex, but differences by age. Right? Now, these differences aren't huge, but they're not null either. Now, every conference I go to these days says, you know what? The equation doesn't fit well in diabetics. We should have a diabetes-specific equation. The equation doesn't fit well in kidney transplant recipients. We should have a kidney transplant recipient equation. This, in fact, is in the manifest of the KDIGO kidney transplant work group, right? The equation doesn't fit well in older people. We should have an older people-specific equation. It doesn't fit well in HIV patients. It doesn't fit well in liver transplant patients. It doesn't fit well in patients with heart failure. Right? Now, we could have improved the fit in people with diabetes. Right? But you can see immediately it would have made the fit in the non-diabetic patients worse. And you can improve the fit in any subgroup you want by developing a new equation in that subgroup, and you can publish on it, and you can have controversy. And we love controversy, but after a little while, you know, it impedes progress. The more important thing to note is that in each subgroup, the performance of the creatinine cystatin equation, okay, is a little better than the performance of either. The creatinine cystatin equation improves things not by changing the bias, but by changing this 1 minus p30. This is just the inverse of the p30. And you notice that in every subgroup, diabetic or not, the performance with the creatinine cystatin equation is better than the performance with the creatinine equation. So what do you do if you have a patient who you think is in a subgroup that creatinine's not accurate enough? Don't use a subgroup-specific equation, because which equation do you use? If you have a patient who's diabetic and has liver disease and has cancer and is older, right, has HIV, which equation are you going to use? You don't use a different equation. You use a different filtration marker. Right? So the two questions that we were asked is, which equation do you use? And which filtration marker do you use? So certainly for subgroups, it's a matter of for confirmation, it's a matter of using an additional filtration marker. This is just some data where we compared the error in indexed versus non-indexed eGFR compared to indexed versus non-indexed mGFR, and the errors compared to mGFR are the same. Selection of which equation to use. I thought the evidence review team might take this on. I think they may not have the appetite for this. I think that's unfortunate. This is actually pretty important, right? Because after all, if you don't, we will just have the Tower of Babel, right? If every group is free to say, you know, I'd kind of like to use this equation, I'd kind of like to use this one, I'd kind of like to use this one. That's like each group saying, my MRI machine gives me a nice image, I'm not going to compare it to your MRI machine. So I think that we need some standards, right? And I think that there should be some rules for how you assess equations. It's not accuracy alone, right? There's the assay. Do we have assays for the markers? Were the equations developed in representative populations? And this means the full range of race and ethnicity. Accuracy is important, and can it be implemented? How well can it be implemented? And then I think the comparison of accuracy requires uniform analytic methods. The metrics have to be defined in advance, and they have to be calculated the same way. Subgroups have to be defined the same way. The mGFRs need to be calibrated, and if they can't be calibrated, we have to make some assumptions about calibration and do some sensitivity analysis. We have to have uniform methods for description of the effect size and description of the uncertainty around the estimates of the effect size. This is currently lacking in our literature. The literature, I think, is not very good. If you just do a systematic review of what the literature says, you come up with conclusions that can't be substantiated. So I think that for improving quality of care, We need to appreciate that the guidelines said this before, but there are new equations since then. And I think there should be a comprehensive assessment of these equations, and there should be a rigorous assessment of the accuracy of new equations. And I think this is going to include individual patient data analysis. I've spoken with the leaders of the European Kidney Function Consortium and said that we in CKD would be willing to try and undertake this. We're not the only two groups that have developed equations that have data, but so far we have the most data. And I think that KDIGO should ask for this, because without this, it's just the Wild West out there. For example, the European Kidney Foundation Consortium developed a new equation, published it in the Annals of Internal Medicine, and concluded that it showed improved accuracy and precision compared with commonly used equations. Leslie Inker and I, with our statistician Hossein Tigawar, were asked to write an editorial, and we simply analyzed the new data compared to our equations, and we concluded that it represented a conceptual advance over the FAST equations, but the claim of equivalent or superior performance wasn't conclusive. Right? We couldn't reproduce the data. Right? I don't think they're wrong. Right? I don't think they did the wrong thing. Each group has their own data, but each group can't have their own methods. This is a diagram that we frequently use to compare different equations to a reference equation. We took our equation as the reference equation. Red means worse, green means better, right? And you see this is how the other equations performed in overall in blacks and whites. If we calibrate, if we do a sensitivity analysis calibrating for the difference in the MGFR methods, we actually get a different answer. We've done the same thing using the race-free CKD Epi 2021 equations, right? I think this should be of interest, right? And we've done it with and without calibration, and you actually get different answers. We need to make recommendations based on uniform methods, not on studies and reports that use different methods. So as far as improving quality of care, I think we need to improve the accuracy of GFR evaluation and use GFR assessment in the context of the clinical setting. We need to understand the accuracy of methods for MGFR and EGFR, and we need to use information in addition to GFR for decision making. We need to continue EGFR as the initial test, and there's a big benefit of uniform estimation, but there's some trade-offs too. We need wider implementation of automatic reporting of EGFR by clinical labs. Consider reporting it indexed and non-indexed. We need to evaluate newer equations, but I doubt that accuracy can be improved for creatinine equations substantially because there's inherent variation across populations. We need an evaluation across multiple domains, not accuracy alone, including the development and representative samples, but not subgroups. I think we need to resist this false appeal. And we need a standardized performance evaluation that I think can only be done in individual patient data analysis. We need more frequent use of confirmatory tests. Cystatin C is recommended, but terribly underutilized. We need to make statements in the guidelines that improve the utilization. And we need to improve the validity of measured GFR. I think there should be standardization and calibration. And I think a panel eGFR is in development with novel markers, and I think this should be encouraged, but we're not there yet. I think I'll stop here. I have a number of suggestions for research aims, but our group will probably go over this and improve it. Thanks very much.